Okay, so we're going to start this. The first part of this talk is just basic stuff. And I include it into the talk because it's all very common sense, and most of us understand this intuitively if you've done laser eye surgery before. But actually, it just reminds us again and again what we need to have in our minds when we're dealing with patients in terms of aftercare. Again, when you treat an eye, you don't get a final result on day one. We know that. But the patient doesn't know that. They see these adverts on TV. It's like, you know, come on, the person's so happy on day one. But in reality, there is a healing phase that they need to go through. So the more we understand about that, and the more we can show our confidence during that early healing phase, it just makes them much more relaxed until they finally get the final outcome that they need. So we'll talk a little bit about some of these features as we go along. Okay, obviously, as we've talked about a lot, this is a system. And the system helps us because if you educate people before the surgery about what to expect after the surgery, when things happen to them after the surgery, which are normal, they understand that it's normal because you've told them about it beforehand. Okay. So all of that is very important. What helps us to get very good outcomes is, again, as we said, having a very good refraction technique, yeah, with a very hard endpoint. I drilled this into everybody earlier. And you'll see with a lot of these unhappy patients afterwards, sometimes the smallest refractions make a big difference. It's amazing. We are dealing with a system that has one eye doing the heavy liftings for distance and the other for near, and they summate. We use them together. But it really is one doing the heavy lifting for each one of those activities. So they need to be pretty close to their targets to have a happy patient. The blended vision acceptance tolerance assessment is very much a key part of the treatment as well. And you'll see in a few of the examples later on how we learned how important this is as well. We go into a lot of detail before the treatment, explaining to the patients that they may need enhancements. And we take it for granted. Someone's not on target. You just tweak them and you'll get them better. But they don't always see it like that. They'll often come in and say, the surgery hasn't worked. And you will say, well, you were minus 12, you're now minus a half. Of course it's worked. You're just not on target. Your eye is not a piece of plastic. That's my favorite little thing. It's biological tissue. It can heal. And you can't control your healing, and neither can I. It just happens. So we learned from treating thousands of people how most people heal with your prescription at your age and et cetera, regression analysis for your nomograms. And we try and guesstimate what you're going to do. But some people are very good at healing and some are not. So not everyone will be on target. But it's important to explain the one thing that they do need to understand is if they're not on target, yes, we can enhance them. And that's very different to someone who's a little bit blurry but can't be improved. That's risk of damage. We make this very obvious to the patient that, again, there's always risk involved, but being off target is not so much a risk because I can improve on that. I can do a bit more treatment for you. And we reinforce the blending process. This is in the aftercare at every single visit. Day one is a really critical time because there's a lot going on, and we've given it to them in paperwork and things like that as well. So we can always say refer back to page 3 where it talks about swelling on day 1, and that's why you're still a bit fuzzy and things like that. So you've got to be able to reinforce this a lot. We also preoperatively warn them that there's 3 phases of healing. Again, this helps you get through the early phase when you've got patients who are like, whoa, why am I not perfect? Day 1, you're going to have slight discomfort. You'll have a dry eye sensation. You'll have a lot of night vision halos because you've got tons of swelling. Slight blurring because you'll be slightly off target. You should have a slight overcorrection in most people. And the higher your starting prescription, the more overcorrection you'll have, as you'll see in a few minutes. And you should expect visual fluctuations from all of these reasons. Over the first few weeks, you should still expect some vision fluctuations. It might be morning to evening or day to day. You might have very good near vision and slightly poor distance, or the other way around. And again, it depends on what treatment you had. In other words, were you hyperopic or were you myopic? Myopics, they're going to see better at distance in the beginning because they've got a little overcorrection. They're a bit long-sighted. And vice versa for the hyperopes. And of course, once you get to 3 to 4 months, most of the stuff is healed. And now we're just dealing with the last bit of adaptation. Yeah? You bought your new car, and it's taken you a few weeks or a few months to fully get used to it. I bought a Tesla. It's a weird car. can't park these things. It's got nothing. It's a weird car. I don't know if I like it. Anyway. All right. So the point is there's 3 phases of healing, and they need to understand it. So we do this little drawing for these patients, again, preoperatively. We show them that there's 3 phases. Overnight, you're going to see a huge improvement in your vision, and some people heal slower, and some people heal much quicker. On top of that, you're going to get a lot of night vision disturbances in the beginning, and that's a given, 100%. Everyone's going to get them because you've got swelling inside your cornea. But they get better, and some people quicker than others. And then, of course, fluctuations from all of these small side effects of dry eye and swelling, etc. The second part of it is dry eye. And again, dry eye will usually last for 3 to 6 months. Some people a bit longer, some less. And if you've had SMILE, you're bound to get less dry eye than the LASIK patients. We'll talk a lot more about that tomorrow. And the final part, again, is this cross-blur adaptation. Now, we do offer a lot of follow-up, yeah? So during the process, we're going to hold your hand. We're going to help you with your dry eye. We're going to help you with your night vision side of things. We're going to help you with your adaptation as well. If you need some interim glasses, we can make them up for you. If you need glasses for driving at night because you're slightly overcorrected, you're a hyperope, and your distance is a little fuzzy, make them up some glasses. Keep them productive. They're just there in the cubbyhole when they need them, or maybe for going to the movies. And I explained to them, at some point you'll get in the car and drive and you won't need them anymore because your eye will have regressed a little bit more and you'll now be on target. But I'm treating you to get a good long-term target. So you need to be a bit overcorrected in the beginning. It's that whole logic. They need to know how the system works. And of course, yeah, a few people won't get there. A few people will still have cross-blur at 1 year. And we need to help them. So a lot of these people refuse more surgery, because they'll say to us, I only wear my glasses now 10% of the time, maybe for driving at night when it's raining. The rest of the time, I can manage very well. Rather than reversing the blend and having both eyes distanced, and then I need readers 50% of the time, I'll stay as I am. But of course, you can adjust them very, very easily. So we have about a 95% spectacle-free rate at 1 year, which shows you how effective these treatments actually are. Again, you've got to use the full system to your advantage because that's what gets you out of jail. The more knowledge you can give people, your patients, and the more times you can reiterate it, the happier they are because they understand the process. So let's talk now a little bit more about cross-blur and the adaptation time. So what is cross-blur? Well, it's when the patient actually notices that there's a difference between their eyes when they're looking at something. That's really what it is. I'm looking at the audience, and one half of it is a bit blurry, and the other half is clear. I'm left eye dominant. So they might require glasses and things for certain activities to balance the eyes or reduce the amount of anisometropia. But they really will always feel a little bit uncomfortable. This is exactly what they describe. It just doesn't quite feel right at this point in time. Now, the group of patients which tend to notice and have the most amount of cross-blur is the emmetropic group. And I think it's because they've had years and years and years of just using both eyes all the time on tap. And then you take one eye and you make it a bit more fuzzy for reading, and that's the group that kind of gets a little bit more. So compared to the myopes and compared to the hyperopes, that's the one group where it stands out a bit more. Oh, and by the way, if you treat somebody who has pre-op anisometropia, so a big difference in the refraction, they never get cross-blur. Because every time they're not wearing their glasses, they're using one eye. That's a bonus. If somebody's mildly amblyopic, 2025 and 2016, easy. Because you just, obviously you'll keep the 2016 eye for distance and the other one for reading. They do very well. But when you look at our emmetropic group, which was the most difficult group, yeah, in terms of adaptation, at 3 months, 76% of them had fully adapted. But it doesn't stop there. The brain doesn't stop getting used to and the difference in the eyes. You continue to summate, and at 1 year, we saw 94% acceptance. So you just got to be holding their hands through those last few more months, and most of them will get there. Most of them will get there. So we had 3% of patients who weren't very happy at the end. Okay. And of course, as I just mentioned, you can just give them glasses. Now, most people would think if you've got somebody who's got cross-blur and they're saying, I'm battling driving at night, the reading eye is bothering me at distance, you're going to make up a pair of glasses and just move both eyes to distance. But the truth is we very rarely do this. We sit with the phoropter and we titrate them. So instead of, if they're minus 150 on target in the reading eye and planar in the distance eye, we won't make them a minus 150 pair of glasses in the reading eye. We'll make them a 0.75 or sometimes even a half. We give them enough to, we titrate them up to see when they start feeling comfortable. And that's what we give them. And that way, when they're wearing their glasses, they can still see the dashboard. Yeah? They've still got intermediate vision, and they're still blending. When they're wearing the glasses, they're still getting used to it. And the rest of the time that they're not wearing the glasses, they're actually still putting it all together. You see? So don't give them the full correction unless they really need it at the end of the day. And of course, if you get to the end of the day and somebody is just really miserable, they were a poor candidate, and they somehow got through the system of your checks before the treatment, and it turns out it's just a disaster, well, no harm done. Just take both eyes and enhance them. And again, we'll always titrate them. So I've had patients over the years who are on target at a year, yeah, and you always give them a year. Give them a full year to see if they get there, all right? Don't be tempted to enhance them too soon. Because again, most of them will get there. But I've had patients who are minus 150 in the reading eye, on target at a year, and hated it, and I titrated them, and I saw, if I brought them to minus 0.75, they were comfortable. So we discussed, I'll take away some of your small print, you'll still have a bit of intermediate, and we enhanced them to 0.75. And I said, right, off you go. And we followed them up for the normal second-year annual care, and I got them back at another year later, so they had 3 years now. And now I simulate again for them the extra 0.75, back to minus 150, and now their brains have totally adjusted, and they accept it. And you do a second enhancement, and you take them straight back to where they were. But now they're super happy for the next however many years. So again, as you get more and more comfortable with your enhancements, yeah, it's less intimidating in terms of moving people around and adjusting them and giving them what they really need. But some of them don't. Some of them you have to stay at the 0.75 or even take them back to both eyes planar. It's just how it is. And remember, if you're enhancing people, you want to see good stability, all right? So again, very rare to enhance someone before 6 months, but if it's blended vision, try and string them out. If they're off target, you need to enhance them sooner, but if they're on target and it's cross blur, they just don't like the difference in the eyes, string it out to a year. Give them a chance to get more adapted. So what do we need to be aware of as clinicians? This is all very obvious stuff, but I'll quickly run through these slides just to kind of fresh our memory as to what we're dealing with. Remember, again, we're not dealing with a piece of plastic. You're changing the shape of the cornea with a laser. The laser is super accurate. It'll change the shape exactly as we want it to, but the eye will heal a little bit. The epithelium thickens, there's biomechanics, there's thickening of the stroma in certain places. So the prescription will change over the first few months. And it's all related to whether the patient's exactly on target or not. So what is the expected refractive course for any patient? Well, if you treat a myope, you're expecting on day one for them to be a little bit hyperopic. Yeah? We all understand this. Your nomograms should be set for this. And that's because the epithelium thickens after flattening the cornea, a little bit in the center, and you get a myopic ship. Yeah, so you get regression. And that happens very quickly in myopes. And in fact, most myopes will stabilize fully at 3 months. Hyperopes have more regression because the rate of change of curvature in the periphery is higher, so they get even more thickening of the epithelium than the myopes get, and hence they get more regression. So you need a larger overcorrection on day one. This would be a good outcome for you, right? And they take longer to stabilize, normally up to 6 months. So in fact, when people ask us, when do we set our nomograms of what results, the myopes, you can set your nomograms from your 3-month results, but our hyperopes we do from our 1-year results. But probably 6 months is fine, unless you're doing super high hyperopia. So we need to be aware of this, yeah? When they come in on day one, when the patient sits in the chair with me, the first thing I say to them is, thanks for coming in, come take a seat. Let me explain what we're going to do. I'm going to check your vision, but I don't really care what you can see. It's exactly what I say to them. I'm not fussed with what you're seeing today. What I do care about is what I see on the slit lamp, your healing, because then I can adjust your drops and everything. Your vision will be much better today, but that's something we're going to check at your next visit when everything else is settled. And it's not really being interfered by the edema and by the dry eye and everything. It's being affected by the overshoot. Yeah? So that's the whole idea. Okay. So what do we have to be aware of? We've got to be aware of small overcorrections, large overcorrections, people who are on target and undercorrection. So let's look at all the different time points. We'll just look at a few. Day 1, we expect myopes to have, the mouse is not getting to you. There we go. Okay. For myopes, we expect the distance vision to be good because they have a bit of a hyperopic overshoot, and the near vision to be a little bit difficult, yeah, especially in the reading eye. The reading eye will be a little less myopic than it will eventually be because it needs to regress a little bit. The epithelium needs to remodel. And for hyperopes, it's the opposite. They have great reading and a little bit of more fuzziness at distance. Yeah? At 1 month, if you have a small overcorrection, the patient might not be entirely happy, but we will explain to them, we expect more regression. This is myopes and hyperopes. This is not your final result. It's actually good that you're a little bit overcorrected because we're expecting more regression, epithelial remodeling. And we expect more regression for the hyperopes, and we expect more regression if you had a higher prescription. There's more epithelial remodeling. But bearing in mind, they might be slightly off target, and that might be also affecting their PRESBYOND, their adaptation. You can't really expect someone to completely adapt if one eye is a little bit more off target, right? It's not fair. If they have a large overcorrection, they're not going to be happy. They're going to be complaining. But there's still a chance that their refraction might regress to their target. So you give them a lot of support. But here's where you probably want to already even offer some temporary glasses. Keep them productive. Yeah, I don't want to go to the movies because it's still so blurry. You can go to the movies. Just wear the glasses as top-up. Yeah, it's not the end of the world. And you might even at 1 month start saying, you know what, we're going to watch you, but if you don't quite get there, don't worry, there's always an enhancement that can be done. If they're on target, they're going to be very happy, but we're not so happy. Why? Because we're still expecting more regression at 1 month. Remember, they only stabilize at about 3 months if they're myopic and 6 months if they're hyperopic. So now we're sitting there going like this, please don't regress, yeah, kind of thing. But of course, we're going to see them again at 3 months. And if they're undercorrected, well, no one's happy. They're not happy, I'm not happy, Tim's not happy because I crapped all over him because his nomogram is crap. Because they're undercorrected. No, I'm joking. It's not his fault. It's biomechanics. But yeah, they're unlikely to improve. They're going to regress even further. And you offer them interim glasses, and you're really talking enhancements. And these are the ones that you're almost looking really closely to watch them because you want to enhance them soon. They're never going to get better. If you're undercorrected, you're only going to get more undercorrected if you regress. So we're really just looking for early stability so we can get in there and make them happy because they've been shortchanged from the beginning. They just didn't even get a taste of the good stuff. As opposed to somebody who was there in the beginning and then regressed. At 3 months, if you've got a small overcorrection, they're probably happy, but not entirely. We don't expect more regression for myopes. So you're going to have to watch these people because a couple of them you might still want to enhance, although you might get a little bit more regression. The hyperopes, yeah, the jury's still out. They could still regress a little bit further. And again, keep them supported with some interim glasses, maybe suggesting enhancements. We don't like to talk about enhancements unless you really need to, right? Because it's negative. Yeah? Only positive news whenever you talk to people. If they have a large overcorrection, they won't be happy. They're also very unlikely to regress if they're myopic. So now you're looking for stability, your first chance every 2 months, remember? Tell them 6 to 8 weeks, but book for 8, yeah? And yeah, you're already discussing enhancements, putting it on the table. Get them teed up. If they're on target, then everyone's happy, providing they don't have crossblur. It's the final result for myopes to a large degree. Again, might get a bit more regression for the hyperopes. And if they're undercorrected at 3 months, no one's happy again. And here's where you really want to consider an early enhancement. At 3 months, most people are going to be fairly stable. But again, book them for 8 weeks' time. Confirm the stability. Otherwise, you're just enhancing a moving target. Okay. So you can see that it's all pretty obvious. And I don't like showing this slide anymore, in a way. If you look at these enhancement rates, they are super high. 19% for myopia, 22%, 12% for emmetropia. This was after a year. It's like 1 in 5 people having enhancements. But this was from Dan's original study on PRESBYOND. And just bear in mind, we did half of these enhancements we did on patients who were 20/20 or better. So in other words, if someone was 20/20 but could see 20/16, we enhanced them. It was for the study. You had to be as perfect as you could be. If somebody was 20/16 and could see 20/12, we enhanced them. Yeah? That's how it worked. Someone was N5 and they could see N4, we enhanced them. So I'm saying this is not a fair representation, but you do more enhancements with PRESBYOND because you need one eye that's very good for distance and one that's very good for near. If somebody is a half a diopter off target and they're happy, that's fine. We're happy. But if they're not, you're going to enhance them, as you'll see in some of the examples we'll go through. So really, this was crazy times, but it was getting people from good to great. Now, what do you do if you need to enhance them? You just use PRESBYOND profiles again. Nothing to do. You just got to see if the spherical aberration is not super high. You get some outliers. So if you performed your original treatment and the spherical aberration is somewhat toxic, it's very high, then program the spherical aberration in again. Otherwise, you can just leave it blank. Now, this is a great little calculator that I put together. It doesn't show up. So basically, I was having lunch with Tim one day. I've told the story many times at the course in the past. And I thought of this idea of having a visual representation for patients. So if I'm sitting at my desk and I've got a patient and I'm trying to explain to them why they're still bothered with their blended vision, why is it not comfortable for them? So what I could show them is, if, for example, your right eye is at 0. It's great for distance, so you're loving your distance vision. You can see your distance is good. There's the bar showing your distance, and intermediate is good. But your near eye is sitting at -125 at the moment, which again is explaining why you're loving distance and intermediate. You've got crossover, but your near is a little bit short-changed, and that's why you're struggling with small print. And then I would say to him, now all I need to do is do a little tweak on your reading eye and move it from -125 to -150, and you just click on the little thing and it just shifts across. And then you can show them that's the optimal position. Now your vision will be more comfortable. And then you show it to them in the phoropter, what difference the quarter would make, right? So I got him to build this for me on Excel. And then when we started doing the course, I said to him, let's put this in there so we can show you guys where people are diagrammatically, in each of these cases we're going to go through. And he was like, this is amazing. Who did this? And I said, I did it. And he was like, I didn't know you could program Excel like this. It's pretty impressive. It was amazing. And he completely forgot that he did it for me. I wouldn't even have a clue. Now, you have a version of this. It's been neatened up. It's been made to look much smarter. And again, it's on your memory stick. So if you want to use this little tool with your patients and show them when they're not exactly on target, you can use it with pleasure. So these are all the possible outcomes that might require an enhancement. It's all very, very straightforward, very obvious. If somebody's not exactly on target, something's going to be good in the vision and something's not going to be good in the vision. Yeah? I don't think I need to go through that in any more detail. So let's look at some clinical examples, and we'll see how sometimes a little bit makes a big difference for some people. So this is what the new version of the simulator looks like. And again, it's mobile. You can move these little sliders across, and it's just nice to represent to patients. This patient would be slightly overcorrected for distance eye and the reading eye, and so they've got a gap in the intermediate. And they'll tell you, computer is difficult. I can see in the distance, I can see up close, but I've got a gap. And then you show them with enhancements, or you might say, I expect you to regress a little bit more in your distance eye, but your near eye might need a tweak. We're going to work this out and follow you up. Yeah. As opposed to what would be ideal. Okay, so let's look at a few cases. This is case 1, where this was the intended outcome, to get the distance right eye, the left eye to -150 for near. And where did we end up? Well, the patient was on target for distance, plano, but the near eye was at -225. So what are you going to expect? They're going to say, my intermediate may be a little bit tricky. I've got to hold things a little bit close for reading. And my distance, whoa, hang on a minute, this feels a bit weird. Because the near eye is a lot more fuzzy at distance than it needs to be, right? And Well, I mean, you can just see how many visits it took to keep this patient calm and on board. But yeah, I mean, look here. We aimed for a -125. So the patient had poor tolerance to begin with. Yeah, we realized we couldn't do a -150 even because they were a bit sensitive, in our tolerance testing. And unfortunately, the patient overcorrected. The distance eye was absolutely perfect, 2010. It's at 7 months. So obviously no enhancement needed on that side. But because the patient had cross blur, we had to do something about this -2, -0.25. So the patient was actually saying, my distance is okay. Well, it should be okay if you're 2010. But I need glasses for TV and night driving because of the confusion. Yeah, this is cross blur. It felt uncomfortable. I can see, but it feels a little bit uncomfortable. Patient was a surgeon, so struggled in surgery a little bit, and again had mild cross blur when looking close, because when he was looking close, you had to bring it closer than normal, which means the distance eye is a little more fuzzy at near. It's not at a normal reading distance. It kind of worked both ways, yeah. So anyway, we enhanced the patient and aimed for 150, actually, titrated to treat -0.5. Actually ended up -175 on day 1. Patient was now super happy, but defaulted follow-up. So, I mean, this is a group of eye surgeons. If this patient, I've got a picture of the patient. If they ever pop up in one of your practices, you can just point them in the right direction, because even though he was fairly happy, we wouldn't mind seeing him for another checkup. So this was Dan, of course, yeah. So even Dan's had an enhancement in one eye. He has had more checkups, don't worry. Okay, case number 2. A hyperopic patient where the near eye was on target, -150, but the distance eye was still a little bit hyperopic, +0.5. And again, what are you expecting to see? Probably the near is good. The far distance, like down looking at the sun, is good, the moon. But computer distance will be tricky, yeah? So let's see. Here's the outcome. The patient was a plano patient. And the patient says to us, this is at 1 year. What we see is there's +0.75, -50 at 42. Patient says, the vision's just the same, nowhere near as good as he wanted it to be. Up close, he has to close the left eye. Yeah? Well, it makes sense. It's hyperopic. It's not doing anything of any much help for near. And the other way around for distance. Yeah, it has to close the reading eye to really get that accommodation going to help with that 0.75, I suppose. And in the intermediate, nothing matches up. And again, we understand all that, right? It makes sense to us why they would be complaining of this. So an enhancement was done. No enhancement on the right eye and the reading eye because it was nicely on target, but the left eye treated with the +0.75, and you can see the uncorrected vision actually improved dramatically with that +0.75. There was a little bit of oblique sill here as well. Oblique sill is never a great thing, yeah? If it's with the rule or against the rule, it's a lot more forgiving when there's a half. But sometimes a half that's oblique, you'll see in another patient later on, is not easy for people. So again, these are the examples where you can trial frame someone. If you're not sure, because you'd think that spherical equivalent should be fine. I mean, they should see fine. Spherical equivalent is +1/4. But in real terms, it actually does make a big difference. Case number 3 was a mini blend. This is just an interesting case, which showed up a couple of interesting features. So this was a patient who didn't tolerate a full blend, so we intentionally did a mini blend, 0.75 in the reading eye, and the patient ended up, yeah, pretty much on target with a -1. So this was a consultant ophthalmologist, 55-year-old with low hyperopia, +150. The right eye was the dominant eye. That's why we obviously treated right eye to pure distance. And again, and this is pre-op, in the tolerance testing, didn't tolerate the 150, so we agreed, do the 0.75. You're only going to get a taste of reading. You'll still wear top-up readers, yeah? But you'll have a lot more reading freedom than being +150 walking around in the world. So that's what we aim for. And it was agreed that there would be insufficient near vision. The surprise from this, and this is just to show you, sometimes you get a little bit of a, yeah, it works out in your favor. The patient ended up, yeah, pretty close to target, -1. You could argue it's a -1.13 when you can add the sill as a spherical equivalent. But look at the vision. I mean, amazing. This eye, the distance eye, 20/40, N24, 20/16, N5 with a -1/4 at the age of 55. And the other eye, 20/25 -2, N4 with a -1. How does a -1 eye see 20/25 -2? What he has is huge amounts of depth of field. So the way his eye healed is just he's an outlier. So he was super, super happy. I mean, stereoscopically, 2012, he summates with 2 eyes because he's got all this depth of field. And he's got 40 seconds of stereo, unaided, operates with no extra dialing in of the eyepieces or anything at the microscope. He just uses his eyes unaided. Yeah. So the spherical aberration is very powerful, and sometimes it gives you a lot more bang for your buck. That's really cool when that happens, but doesn't always happen. And the point about this was that if he hadn't got that extra spherical aberration boost and was struggling a little bit with the fine print, this is the example where at 1 year, you would then re-simulate them for the full blend. And if they now tolerate the full blend, you can give it to them. Yeah, they've had time to adapt. Their brain has learned. You're not having to lift the big, heavy weight all at once. You've got a medium-sized weight, which you got used to, and now you pick up the second one. Yeah, okay. Case number 4, noticing blur in the non-dominant eye. So this is an interesting case. I'll show you a little video with this case. I think it's this one. The patient comes in with lots and lots of cross blur, and they were visibly, as is what the optom has written, visibly stressed. It's not a comfortable feeling, and it's bothering them, and they're actually feeling quite, why did I do this kind of thing? Patient says, the distance is good, but I'm constantly aware of my left eye. And I'm walking around closing my left eye the whole time and just using my right eye. So obviously you know the right eye must be the distance eye. Yeah? Distance is good. I have to close my left. So what are you thinking is going on here? You think the left eye is 2-, right? And they can't tolerate it. Intermediate is good and the near is good, but sometimes aware of the right eye. So look at this. Interesting. The right eye, which we said would be good, yeah, they have to close the left eye. Patient has to close the left eye. That's the reading eye. The right eye is actually -1/2. The distance eye is -1/2. Interesting. The reading eye was effectively -2. So they're both slightly undercorrected relative to the target. In fact, we aim for -175 on the reading eye. So watch what happens here. Let's play the video.
Okay, so you can see in the distance, but you're aware that the left eye is blurred.
That's right, yeah. That's blurred.
The left eye?
The left eye's feeling is blurred.
The right eye doesn't feel blurred?
No.
Right eye is -1/2.
-1/2 in front of the right eye. Are you aware the left eye is blurred?
No.
Not at all?
Not at all.
Okay. And
magic.
now,
Yes.
the left eye becomes blurred?
Yes.
Yeah.
Left.
What's going on here? There you go. So what's happening here, it's interesting. The brain is dealing with a situation, interesting, just follow me on this, where the reading eye is at -2, where it should be, quite blurry at distance, even with the depth of field. The distance eye is at -1/2. So the distance eye is trying to see at distance, but it can't manage because it's -1/2. So it's calling a friend. So what it's doing is it's constantly saying to the left eye, come and help. And the left eye is going, whoa, what are you talking about? I'm -2. You're the one who's supposed to be doing the distance work on your own. Okay, I'll come and help. And so he's constantly being aware of this left eye because it keeps on coming in to help. That's what his brain is doing. It's not his eye. So as soon as Dan puts the -1/2 in front of the distance eye and corrects it to full distance, the brain goes, that's what I'm looking for. I can handle this on my own, and it switches off the left eye. And the cross blur disappears. Interesting. So in other words, you have to be on target, yeah, to see well. This is a case of blur in the distance eye, not really cross blur, but it's blur in the distance eye which is causing more cross blur because it's calling in the other eye. Okay, so it's important to double check which eye is actually causing what And is it the balance between them that's being upset because one of them's not doing its job fully? Love this case. Okay, case number 5. There's only a few more. Distance eye is on target, and the near eye is on target. Okay, that's interesting. So in other words, we aim for the distance eye, left eye, 0, right eye, minus 150, and that's exactly what we got. So we've done our job, the healing's done its job, the laser did its job. So this is quite a rare case, and nowadays we don't get caught out as much. But have a look at this case. We decided that the right eye was the non-dominant eye based on our testing. We did the tolerance test before the surgery and showed that with a minus 150 there was only minimal cross blur. So we aimed for minus 150. This was a minus 0.75, minus 1 to start with. And the patient at 14 months, bang on targets, bang on targets. That was the dominant eye. Everybody did what they had to do. Not happy. Large amounts of cross blur. The vision just does not feel comfortable at all. I can't deal with this. So what do? We did a whole bunch of simulations, and then one of the optoms very cleverly thought, what about if I just reverse the dominance? Let's try that. And in doing so in the simulation, it was like someone lifted a weight off his shoulders. The vision was just perfect. So we got the dominance the wrong way around in our testing. Now in those days, you can see here it's 2011, this is how you learn. We weren't doing the double check. We weren't doing the reverse dominance check in the phoropter to see which one they really preferred. The dominance and the testing was a little bit of 50-50, but actually if we had actually tested it preoperatively both ways, we would have learned very quickly that they liked and preferred the right eye to be the dominant eye, the distance eye. So that's what we did. We just reversed it. And you can see the patient again 11 months later after enhancement, on target and super, super happy. So we created a lot more work for ourselves in the process for this particular patient, and that's why we do the double check nowadays. It takes 5 seconds to do it, and every now and then you get caught out. There are not many of these people. I think there's only, well, there you go, 3 cases in 14 years that we've had to reverse things. But bear in mind, we've been doing this since 2011 when we discovered this one. Yeah, for the last 13 years, we always double check. So it's worth double checking. Okay, case number 6. This is the one I was talking about with the small residual astigmatism. So this is a patient, 2025, post-op, at distance plus 2, N4, 10 months. The reading eye, perfectly on target, minus 150. The distance eye, plus a half, minus a half, at 46. Again, who's enhancing plus a half, minus a half? Not many people. But if you look at the axis of the astigmatism, it's oblique. And again, this can be it can have quite a marked effect. Even a half a diopter of astigmatism, if it's oblique, it stands out a lot more than if this had been with the rule or against the rule. We might have got away with it. And the patient said, when we put that little half a diopter sill into a trial frame, at 35 to 40, I don't know how you guesstimate 35%, but you get the picture, a significant improvement to my distance vision down the passage when correcting the half a diopter of astigmatism. And in fact, we actually added in reducing the reading eye by half to see if that would make a big difference. Well, it didn't really. Another 10% improvement. So we ended up not treating the reading eye, just leaving it at pure reading, and treating, we ended up treating plus 0.12 minus 0.25. The smallest you can actually treat with the MEL is minus a quarter. What happens if you get 0.0000 as a refraction and you're doing PRESBYOND? That's an interesting one. So if your distance eye is 0.00, and the reading eye is 0.00, well, the reading eye is easy, right? Because you're going to make that minus 150. So what do you do with the distance eye? You just leave it. Well, you could if it's got a lot of natural spherical aberration. Yeah? You can just leave it because it's got depth of field. But if it doesn't have a lot of spherical aberration, then you program in +1/8 minus 1/4, and you treat that eye because you're treating the spherical aberration in that eye, not the refraction. Whenever we do PRESBYOND, you've got to think of it as I'm treating the spherical aberration in this optical system, and at the same time, I'm just repositioning the eye to plano and -150, or whatever the tolerance test does for you. It's the spherical aberration that's the big moving factor over here that gives all the comfort, etc. Interesting one. So happy patient. Case number 7, contact lens trial. This was also just another interesting little variation on everything else. Patient comes in, happy, had surgery, but no improvement in the cross blur. Now motivated for an enhancement. The distance is slightly blurred, but that's from cross blur. Patient was actually on target. So this was a -3 patient, -3. Distance eye is bang on target. Reading eye, bang on target. So this is pure cross blur. I don't like my distance. The reading is interfering. So what are we going to do? We're going to treat the reading eye and reduce the amount of reading, right? But we're going to titrate it. So we did in a trial frame. We said, fine, let's give you a -0.50 and see if it makes a big difference. We take away -0.50. We're going to take the reading eye from -125 to -1, -0.75. And it made a big difference in the trial frame. And we thought, in this particular case, we thought, you know what, let's give you a contact lens to take home for a week and trial it. The patient was a previous contact lens wearer. Take the -0.5, just see what it's like in their everyday life. We're going to take some reading away here. We just want to make sure you're comfortable. So this was the phone call a week later. This is quite cool as well. Spoke to the patient. She wore the contact lens. And again, the contact lens was to simulate the reduced refractive difference in the eyes for 1 week. She was very happy with the vision. The cross blur had resolved, and she was now motivated for the enhancement. Well, that's what we thought would happen. However, since removing the contact lens, the cross blur hadn't come back. And when she put the lens back in again, she realized her reading was somewhat compromised. The vision wasn't as comfortable as she was now unaided. So she said, I'm happy with my vision. It's as if my brain has now adjusted. So it's kind of interesting. This goes back to that whole concept of when sometimes you do a small adjustment for someone who's on target and you reduce the anisometropia, you bring the eyes closer, so you bring someone from -150 to -1 because they couldn't tolerate it, and you give them another year, and you bring them back, and now you simulate them back to -150, and they tolerate it. Their brain just couldn't handle the big gap, but once you made it smaller, it could get used to it. And now that it's so used to the smaller gap, it's much easier to add a bit more. So this is why when we pick up patients preoperatively and they're too sensitive in the +150 test and we titrate them down, we're still very happy to treat them. Mini blends, we call them mini blends. And we explain, you won't get all the reading, but don't give up. We won't give up on you either. We'll treat you and we'll see you in 6 months, we'll follow you up. And at 6 months or 9 months, if you've adapted to the mini blend, we'll simulate the rest of it for you and we'll enhance you for free. It's just a 2-stage treatment because your brain needs to be supported a little bit longer. Happy patients. And then I think this is the last case. This is quite interesting as well. Refracting to 1/8 of a diopter. Yeah, it's getting a little bit scary here. So this is a patient who says, fatigued, headaches in the last 9 months having had surgery, distance, constant cross blur, fuzzy blurred vision, takes the glasses off to drive, distance is blurry with glasses, weird, we gave them glasses and the distance is blurry with them, okay. These are the glasses, +0.75, -0.25. The point is the distance is a bit fuzzy with the glasses, but when he wears the glasses, the headache goes away. The intermediate vision has worsened using the balanced glasses for all intermediate tasks. So let's have a look at the outcome. This is a plano presbyope. Sorry, this is from the previous surgery on that side. You can't see the top, but plano presbyope, and the distance eye at 31 months has settled to +0.5. The reading eye is on target at -150. But you can see when the glasses were given, -0.75, +0.75, it was earlier on at 31 months, and actually we're picking up less hyperopia. So when the patient was wearing these plus 0.75 glasses, when we saw the patient at the last visit, it was making them a little bit more myopic. By putting a plus 0.5 in front of the right eye, it resolved the awareness of the cross blur, as we would expect. If you reduced the reading eye by half a diopter, it didn't really change much. So the right eye was the problem, being plus 0.5. And the conclusion was that the cross blur was due to that small plus 0.5. And the reason that they struggled to drive with the plus 0.75 is because it made them minus 1/4. He had actual blur. He didn't have cross blur anymore. He had actual blur at distance. Right. But this was quite interesting. Have a look at this little video.
DRO.
Is it slightly better if I do that?
HCD.
No, I know. Is it better?
You go again.
1, 2.
2's definitely a little bit clearer.
Okay, and between 2 and 3? The
About
same.
the same, yeah.
Yeah, okay, good.
So what this is demonstrating is that this refraction was actually 0.625. That was actually the right refraction for this patient. It wasn't 0.75, plus 0.75, it wasn't plus 0.5, it was plus 0.625. Okay. So this extra little slot on the phoropter, that's what it was made for PRESBYOND, micro fine tuning. I don't think it's used for anything else. It sometimes helps you if you're between two refractions, yeah, and the patient can't quite decide, and they are quite sensitive. Sometimes this comes in to help as well. So don't forget that you do have a 0.12 diopter extra lens that you can put into the mix when you're trying to work out if little bits will help. Okay. And this was the outcome. The patient had that little plus 0.5, 0.625, actually ended up minus 0.25, but super happy. And yeah, glasses really required. Everything is nice and easy, and the headaches had resolved. So I think, what this all is about, what this talk is really trying to illustrate is that PRESBYOND, again, relies on you being on target. And you'll get lucky with a lot of patients. Some people have a lot of tolerance. There's a lot of patients we're saying to them, you should have an enhancement. You're 20/32 at distance, you're plus 0.75, how are you happy? And they're happy. So we leave them. We're not trying to enhance everybody. We used to do that for that study. This is about their comfort. The opposite is more likely to be the case. When they're plus 0.75 and they've got a bit more anisometropia than they need, that depth of field that you get from the spherical aberration can only expand so much. So they end up with gaps in their vision, and hence sometimes small enhancements can make a big difference. So don't be intimidated. Just go back to your enhancement technique lectures, study them in a little bit more detail, get used to loving epithelial ingrowth and managing it, and that's it. The risks are very low when you do enhancements, and they're very rewarding because these patients are often not really comfortable, and these tiny adjustments can make them super, super happy at the end of the day. Okay. Good. Any questions? Yeah. We've got one question quickly. We're going to have a break now, Tim? Yeah, 20-minute break, one last coffee run. And then you've got Dan to finish off with 1 or 2 more lectures. Yeah.
Hello. So you mentioned the case of both the patients that you don't give the full 150 glasses to. You don't give them the full 150 to make them comfortable. And you mentioned the case, this other case of the patient who used a contact lens briefly.
Correct.
Helped it come together. Have you done that where you give them a longer trial of like continuous use of glasses or contacts to try to bring it together for them so they can...
Yeah. So this is a good question. So what happens if you've got somebody who's got cross blur, who's on target, yeah, and they're struggling, and you show them an 050, and they go, wow, that's just so much, that's just like taking a weight off my shoulders. But they're not really keen on having more surgery, and they're a little bit disappointed because they really want the extra reading. You could do a bit of training with them with a contact lens if they're used to wearing lenses. You can give them the half as a contact lens and say, wear it for a few days, wear it for a few weeks. Wear it when you go out for dinner and you want to go watch a movie. You can do the same with a pair of glasses. Use them when you need them. And the point about what you're asking me is, can you train them up eventually so that they don't need it? Yeah, sometimes you can, but all you're training them up for is more adaptation. You're giving them more time for their brains to adapt, is the difference. What you saw there by wearing the lens and then suddenly fixed it, that's quite rare. That's quite rare. Normally, it's a question of, all right, make the anisometropias smaller, and their brains can adapt easier. And we do that with the glasses intermittently. The rest of the time, they've got the full blend, and they're getting used to it, getting used to it, getting used to it. 96% of people will get to a year, and if they're on target, they'll be comfortable and tolerating it very well. There's not a lot of people who are off target that don't get used to it over time. And in fact, we know this because with monovision in the old days, if you made somebody with after cataract surgery -3 and plano, they got used to it. It took them about 4 or 5 years, but they got used to it. Yeah, eventually the brain gives up. The problem is we don't want to have to hold their hand for 3 or 4 or 5 years. So we use the micro monovision in that sense, yeah. Yeah. One more question, then we'll have a quick coffee break.
Do you ever get patients who are unhappy, and the problem is purely that they don't like the spherical aberration?
Okay, so
in those cases, is it possible to do an enhancement where you just erase the
spherical aberration? Okay, so first of all, no one ever knows they've got spherical aberration. You will never know you've got spherical aberration. Second thing, every single person in this entire room has got spherical aberration. It doesn't bother them. Spherical aberration only bothers you if it's toxic. If you've got huge amounts of spherical aberration, like you had treatment with the physics, or something else. No, I'm teasing there. No, if you have toxic levels of spherical aberration, it will bother you, but it will degrade your vision. Spherical aberration does not, you can't see it in your vision. It just gives you depth of field. That's all it's doing. So you would never have to reduce your spherical aberration unless you have too much of it. That's the only scenario, but then it would be toxic. They'll say, I've got night vision problems. I can see halos and starbursts around everything. Yeah? That's the answer. And there's 2 ways of dealing with that. You can do a hyperopic treatment to reduce it, to reverse it. You can do a zone expansion. Yeah. Okay. There's never such a thing as, the more spherical aberration you can get, the better, as long as it's not toxic, which is the whole point of PRESBYOND. PRESBYOND is trying to, in some people, add spherical aberration so they get more than they started because they need more. In other people, I have some people coming to us with 0.8 microns of spherical aberration, and the algorithm will reduce it because they're walking around naturally highly aberrated. They have too much. You don't need it. But most of us are walking around with tinier bits. And so we need to add a little bit to the system, but just not take it over the limit, so they're not toxic.